In medicine, we're usually taught one golden rule above all others. It's first, do no harm.
It's the Hippocratic ideal.
Exactly. You try to fix the patient without, breaking them in the process. But what happens when the only way to save a life is to use a weapon that you know is going to cause some damage? What happens when the bacteria are just so aggressive, so entrenched that you have to reach for something that, frankly, scares even the doctors prescribing it?
That is the paradox we're diving into today. We are looking at a class of drugs that really acts as the nuclear option of the infectious disease world.
Right.
When you open the cabinet for these, you are not looking for a gentle nudge. You are looking for obliteration.
We're talking about aminoglycosides, the heavy hitters, things like gentamicin, tobramycin, amikacin.
Precisely. And if you spend any time with our source material for this deep dive, and we are synthesizing the structural clarity of Kapsung Chapter 45, with the mechanistic rigor of Goodman and Gilman, Chapter 58, you see this tension on every single page.
It's unavoidable.
It really is. These drugs are absolute assassins against gram-negative bacteria. They don't just stop them, they destroy them. They're bactericidal in the truest sense of the word.
But the cost is steep. We are talking about a therapeutic window that is, it's razor thin.
Window feels generous sometimes. It's more like a tightrope. One slip, one miscalculation, and you're looking at kidney failure or, even more tragically, permanent, irreversible deafness.
Wow.
The margin between cure and catastrophe is narrower here than almost anywhere else in antibiotic pharmacology.
So our mission for this deep dive is to decode that risk. We want to understand the mechanics of this weapon. Why is it so lethal to bacteria? Why does it destroy human ears? And how do we use, math and biology to thread that needle?
And we need to frame these not just as chemicals, but as interventions in living systems. So we're going to look at the molecule itself, the specific sort of heist it pulls to get inside the bacteria, the sledgehammer strategy of dosing, and what I call the unforgiving 3 toxicities.
And we'll wrap up with a clinical simulation, a burn patient case study from Kapsung, where we have to make those high-stakes decisions in real time. But first, let's start with the basics. Section 1, the molecule and the mission.
Okay.
I'm looking at the chemical structure in Kapsung, and it's distinct. You've got these hexose rings, usually a central aminocyclitol ring linked by glycosidic bonds.
Same's the name, right? Aminoglycoside.
Aminoglycoside, it's right there.
It's a very descriptive name.
Yeah.
But, strictly from a how do I use this perspective, the shape matters less than the charge. If you look closely at those amino groups in the diagrams, at physiological pH, they are ionized.
Okay, so they're carrying a positive charge.
A massive positive charge. These molecules are polycations. They're just covered in positive charges. And in the world of biochemistry, highly polar and highly charged is basically code for water lover.
They dissolve beautifully in water.
Absolutely.
Which means they absolutely hate fat. They're lipophobic.
Precisely. They are lipid insoluble. They are repelled by lipids. Now, pause and think about the human body. What are all of our biological barriers made of?
Cell membranes, lipid bilayers, fat.
Exactly. So because these drugs are polar polycations, they bounce right off biological membranes. This single chemical fact dictates their entire pharmacokinetic profile.
The whole story starts there.
The whole story starts there. It explains why if you swallow a pill of gentamicin, it is not going to do a single thing for your pneumonia.
Because it can't get through the gut wall. It's just not absorbed.
It just slides right down the GI tract and exits, 99% unchanged in the feces. It cannot cross the intestinal epithelium. So if you want to treat a systemic infection, sepsis, pneumonia, a kidney infection, you have to inject it.
It has to be parenteral, IV or IM.
It must be parenteral. There's no other way for it to get into the bloodstream to do its job systemically.
Kapsung actually mentions that in the old days, we utilized this failure as a feature. If you wanted to sterilize a patient's gut before bowel surgery to prevent infection during the cut, you'd feed them neomycin.
Right.
You knew it would kill everything in the intestine, but wouldn't absorb into the blood to hurt the kidneys.
That's a classic example of turning a bug into a feature, a perfect one. But this polarity also explains why aminoglycosides are pretty much useless for meningitis in most cases.
The blood-brain barrier.
The blood-brain barrier is the ultimate lipid fortress. These drugs just can't get across into the cerebrospinal fluid, the CSF.
Unless there's massive inflammation, right. I think the books mention that.
Yes. If the meninges are severely inflamed, the barrier gets leaky, and you might get some drug across maybe 20% of plasma levels. But generally, no. They don't get into the brain, and they don't get into the eye, specifically the vitreous humor.
But, and here's the flip side, because they are small and water-soluble, they love the kidneys.
Oh, they love the kidneys too much, as we'll see later.
Yeah.
But yes, for clearance, they aren't metabolized by the liver. They don't need to be broken down or conjugated. They just float freely in the blood until they hit the glomerulus in the kidney.
Yeah.
And they are filtered out into the urine.
So you get very high concentrations in the urine.
Very high, which is great for treating a UTI caused by a susceptible organism.
Okay, so we have a drug that is stuck in the blood, can't cross membranes, and is flushed out by the kidneys. But wait, this brings up the biggest contradiction in my mind.
Go on.
The target of this drug is the ribosome. The ribosome is inside the bacteria. If this drug can't cross a lipid membrane, how on earth does it get inside the bacteria to kill it?
This is where it gets fascinating. This is the sabotage. Goodman and Gilman breaks this down beautifully. To kill the bacteria, the drug has to pull off a heist. It has to break into the vault. And it does this in 3 distinct steps.
Okay, let's walk through the heist. Step 1.
Step 1 is the easy part. Passive diffusion. We are targeting gram-negative bacteria bugs like E. coli or Pseudomonas. They have an outer membrane studded with these little water-filled tunnels.
Porin channels.
Porin channels, exactly. Since the aminoglycoside is small and water-soluble, it just drifts through these tunnels, no energy needed.
Okay, so it's in the lobby, the periplasmic space.
Right. It's in the waiting room between the outer and inner membranes. But now it faces the real vault door, the inner cytoplasmic membrane. This is a pure lipid bilayer. And we just established that aminoglycosides cannot cross lipid bilayers.
So how do they get in? This is the core problem.
They have to be invited in, or rather, they had to be actively pulled in. This is the crucial concept that explains a major clinical limitation. The transport across this inner membrane is an energy-dependent process.
It's active transport.
It is active transport.
So the bacteria uses its own energy to pull the poison inside.
Exactly. It's deeply ironic. The transporter relies on the transmembrane electrochemical gradient. We call this the proton motive force. The bacteria is constantly pumping protons out to generate energy, creating a differential. It's negative on the inside.
Like a battery.
It's just like a battery. And that gradient acts like a conveyor belt. It sees this highly positive aminoglycoside molecule and just sucks it into the negative interior of the cell.
But, and I remember reading this part in Goodman and Gilman, that gradient, that proton motive force, is generated by the electron transport chain.
Yes, it is.
And the electron transport chain requires oxygen to function. It's aerobic respiration.
You've hit the nail on the head. This is what we can call the oxygen key. The pump only works, the conveyor belt only moves if the bacteria is respiring aerotically. If there is no oxygen, there is no gradient.
And if there is no gradient?
There is no transport.
Yeah.
The drug is left knocking at the door, and it can never get in.
Which means aminoglycosides have absolutely zero activity against anaerobic bacteria.
Zero. None. Things like bacteroids or Clostridium, they literally cannot enter the cell. It also explains why they work so poorly in an abscess.
Right. An abscess is a walled-off collection of pus.
And that pus is hypoxic low oxygen, and it's acidic. Both the low pH and the lack of oxygen turn off that transport system. The conveyor belt grinds to a halt.
That is a massive clinical takeaway. If you even suspect an anaerobic infection, put the gentamicin away. It is completely useless.
It is a brick. It will do nothing. But let's assume we were in an oxygen-rich environment, like the bloodstream during sepsis.
Yeah.
The drug surfs that proton gradient and bursts into the cytoplasm. Now it is inside the vault.
And its target is the ribosome.
It heads straight for the 30S ribosomal subunit. This is the smaller half of the bacteria's protein-making factory.
And Goodman and Gilman describes what happens next as irreversible inhibition. That sounds incredibly final.
It is. Most protein synthesis inhibitors, like, say, tetracyclines, are bacteriostatic. They just pause the factory, they gum up the gears, but if you remove the drug, the bacteria can eventually restart production.
They live to fight another day.
They do. Aminoglycosides are bactericidal. They don't just pause the factory, they burn it to the ground.
How? What is the specific mechanism of that destruction? It can't just be binding.
It's a brilliant and chaotic three-pronged attack. First, they interfere with the initiation complex. They bind to the 30S subunit and prevent it from joining with 50S subunit to form the full, functional 70S ribosome.
So they stop the assembly line from even being built.
That's the blockade. That stops growth. But that doesn't explain why the bacteria die so quickly.
Okay, what's prong 2?
True. The second mechanism is arguably the most destructive. It causes the misreading of the mRNA genetic code.
Unpack that for me. What does misreading actually mean for a bacterium?
Okay, imagine an assembly line building a car. The instructions, that's the mRNA, say install brake pad. But the aminoglycoside binds to the ribosome and it twists the structure just enough so that the reader makes a mistake. Instead of install brake pad, the worker reads install banana.
Install banana. I like that.
The ribosome grabs the wrong amino acid, a totally incorrect one, and incorporates it into the growing protein chain. So the bacteria starts churning out what are essentially garbage proteins.
Mutant proteins.
Non-functional, misfolded mutant proteins. And these garbage proteins don't just sit there.
Right, they have to go somewhere.
Exactly. Some of them are structural proteins that are intended for the cell membrane. So now the bacteria starts incorporating these defective parts into its own skin. This makes the membrane leaky and unstable. It compromises the integrity of the cell barrier.
Which creates a vicious cycle.
Yes, a positive feedback loop of death. The membrane gets leaky, which allows more aminoglycoside to flood into the cell, which causes more misreading, which makes the membrane even leakier.
It's a death spiral.
It's a death spiral. And that is the core reason why this class is bactericidal, not just bacteriostatic. It tricks the cell into building the instruments of its own destruction.
And the third mechanism, you said 3 prongs.
Right. The third is that they break up the polysomes. Normally, you have multiple ribosomes reading a single mRNA strand at the same time, like a convoy. Aminoglycosides cause these polysomes to break apart into non-functional single monosomes.
So it's a complete and total dismantling of the bacteria's ability to sustain life.
It is. Blockade, corruption, and destruction.
But bacteria are clever. They've had billions of years to figure this stuff out. Resistance is a huge issue. How do they stop this heist?
They have a few ways, but the most elegant and clinically common one involves what I think of as graffiti.
Graffiti.
Enzymatic modification. The bacteria acquire genes, usually on these little mobile DNA circles called plasmids that they swap with each other, that code for transferase enzymes.
Okay.
These enzymes, and they have names like acetyltransferases, adenylotransferases, phosphorotransferases, they wait for the drug. When the aminoglycoside tries to enter, these enzymes attack it. They attach a chemical group to it, an acetyl group, a phosphate group.
Like tagging it with spray paint?
It's exactly like tagging it. But this chemical graffiti changes the three-dimensional shape of the molecule. It's like bending the teeth on a key.
So it no longer fits the lock.
It no longer fits the lock on the ribosome. The drug gets inside the cell, but it just bounces off its target. It becomes inert. This is the primary driver of resistance in the clinical setting.
And I noticed in the texts that different aminoglycosides have different susceptibilities to these enzymes. It's not a one-size-fits-all resistance.
That's a critical point. A bug might have an enzyme that knocks out gentamicin, but doesn't affect amikacin. Amikacin, which we'll discuss later, was designed specifically to have a protective chemical structure, a bulky side chain, that blocks these enzymes from getting close enough to attach the graffiti.
So it's like it has a built-in shield.
A built-in shield. That's why amikacin still works when gentamicin and topramycin fail.
Okay, so we've got the molecule, the oxygen-dependent entry, the ribosomal sabotage, and the resistance graffiti. That's a solid foundation. Now let's talk about how we actually wield this weapon. Section 2. The strategy of killing.
This brings us from the how it works to the how we use it. This is pharmacodynamics, the how much and how often question.
With penicillin or other beta-lactams, the rule is time above MIC. You just need to keep the drug level above the minimum inhibitory concentration for a certain percentage of the day. A steady trickle works just fine.
Correct. Beta-lactams are time-dependent killers. But aminoglycosides are fundamentally different. They exhibit concentration-dependent killing.
Meaning the harder you hit, the faster and more completely they die.
Exactly. The rate and the extent of the killing are directly proportional to the peak concentration. You don't want a trickle. You want a flood. You want a peak concentration that is at least 8 to 10 times higher than the MIC of the bug.
So the metaphor here isn't a stream, it's a sledgehammer.
A massive sledgehammer. One big hit. But there is a second, equally important property that makes this strategy possible. It's called the post-antibiotic effect, or PAE.
This is one of my favorite concepts in this chapter. It's like the ghost of the drug is still working.
That's a great way to put it. The PAE means that even after the drug level in the blood drops below the MIC, so technically there isn't enough drug floating around to kill anything, the bacteria still don't grow.
They're stunned.
They're stunned. They remain suppressed for several hours.
Why? Is it because of that irreversible binding we talked about? The factory's still a wreck?
That's the leading hypothesis. The ribosomes are jammed, the cell is full of junk protein. It takes a significant amount of time for the surviving bacteria to recover, scrub the machinery, and restart protein synthesis. And the bigger the initial dose, the bigger the sledgehammer, the longer this ghost effect lasts.
So if we combine sledgehammer killing with the ghost effect, that completely changes the logic of dosing.
It revolutionizes it. Historically, we used to give aminoglycosides in smaller doses every 8 hours, 3 times a day. We tried to keep a steady level in the blood, thinking that was safer, but we were wrong.
Why were we wrong? What was the flaw in that logic?
The flaw was we were thinking about efficacy, but we misunderstood toxicity. It turns out that the uptake of aminoglycosides into the kidney cells and the inner ear cells, the places we damage, is a saturable process.
Saturable. Explain that like I'm 5.
Okay. Imagine the cells in your kidney are like a sponge, but it's a very small sponge that can only hold so much water. Once that sponge is full, pouring more water over it doesn't make it any wetter. The extra water just runs off and goes down the drain.
Okay, so there's a maximum capacity for uptake.
A maximum capacity. So if you give a massive dose all at once,
The kidney cells fill up really quickly, but then they hit their limit.
they hit their limit. The rest of that huge dose just floats past them and gets cleared by the glomerulus. But if you give small doses constantly, every 8 hours, you keep that sponge wet 24/7.
Right.
You never let it dry out.
And the toxicity comes from the drug staying in the cell and accumulating over time.
Exactly. Toxicity is time-dependent. Efficacy is concentration-dependent. This realization was the game changer. So the solution is the once-daily dosing strategy, also called extended interval dosing.
Give us the logic. How does it work?
We give one massive dose, maybe 5 to 7 milligrams per kilogram of the patient's body weight all at once. This creates a huge peak concentration in the blood. Sledgehammer. We kill the bacteria rapidly and extensively.
And then?
Then we wait. Because we gave it all at once, the levels in the blood drop very rapidly as the kidneys clear it. For the next 18 to 20 hours, the drug levels in the blood are almost zero. Undetectable.
The washout period.
The washout. This long drug-free interval allows the aminoglycoside that got into the kidney and ear cells to diffuse out. It gives the organs a chance to breathe, to recover, to dry out the sponge.
But the bacteria don't start growing back during this time.
Right, because of the post-antibiotic effect.
Yeah.
The ghost is still haunting them. So you're getting continued bacterial suppression during the period of organ recovery.
That is elegant. You maximize the kill with the peak, and you minimize the damage with the washout.
It is the best of both worlds. And multiple clinical trials have proven that once-daily dosing is at least as effective as the old multi-dose method, but with significantly less nephrotoxicity.
Is there anyone we can't do this for? Are there exceptions?
Yes, absolutely. The entire washout concept relies on having working kidneys to clear the drug. If a patient has renal failure, usually we define that as a creatinine clearance below 60 ml per minute, they can't clear that high dose fast enough.
They never get the washout?
They never get the washout. The drug level stays high, and the toxicity risk skyrockets. So for them, we have to go back to smaller, more frequent doses that are adjusted for their kidney function, and we have to monitor them incredibly closely. We also generally avoid it in pregnancy and in neonates.
Okay, that makes sense. Speaking of strategies, let's move to section 3. This idea of the 1-2 punch, or synergy. We talked about how aminoglycosides struggle with thick cell walls.
Right. They are great against gram-negatives, which have that thin peptidoglycan wall. But gram-positives, like Enterococcus or Staphylococcus, have a thick, multi-layered peptidoglycan cell wall. It acts like a fortress.
The drug can't get through the porins.
There are no porins.
Yes.
So the aminoglycoside knocks on the door, but it can't get through to reach that inner membrane where the transport pump is.
So they need a partner, a battering ram.
Enter the cell wall active agents. Beta-lactams like penicillin or ampicillin, or glycopeptides like vancomycin. These drugs attack the cell wall synthesis itself. They punch holes in the fortress.
And once the holes are there,
the aminoglycoside rushes in, it flows through the breaches in the wall, it reaches the ribosome, and it delivers the kill shot.
so the bouncer breaks down the door and the assassin runs in.
It's a perfect analogy. And the result is synergistic. This is a key term. Synergy means the combined effect is greater than the sum of the parts. It's that 1 + 1 = 3 effect.
Right.
If you used penicillin alone on a tough bug like Enterococcus, it's often only bacteriostatic. It just inhibits growth. If you use gentamicin alone, it does absolutely nothing because it can't get in. But put them together.
Rapid bactericidal killing.
That's what you get.
And this is the standard of care for bacterial endocarditis, right? Infection of the heart valves.
Yes. Endocarditis is as high stakes as it gets. You have a vegetation clot of bacteria and fibrin stuck to a delicate heart valve. You can't just suppress it. The immune system can't get in there to clean that up. You have to sterilize it.
You need to kill everything.
Every last bacterium. That synergy is life-saving in that context.
But whether we use synergy or monotherapy, we have to talk about the cost. Section 4, the price of power, the toxicity. We have the unforgiving three: kidneys, ears, and muscles.
Yes, let's start with the kidneys' nephrotoxicity. This is the most common serious adverse event. It happens in anywhere from, say, 10 to 25% of patients treated for more than a few days.
What is actually happening in the kidney? We mentioned the sponge earlier, the accumulation.
The drug is actively taken up and becomes highly concentrated specifically in the proximal tubule cells of the renal cortex. It gets trapped in the lysosomes inside those cells.
Okay.
It causes them to swell and rupture, releasing acid hydrolases that damage the cell's mitochondria and other structures. This leads to acute tubular necrosis. The cells die.
And how do we as clinicians know it's happening? What are the signs?
The classic sign we follow is a rise in serum creatinine, which is a marker of kidney filtration. But here is the key warning sign.
Yeah.
The first thing to change is often the trough level of the drug.
Oh, yeah.
If you are monitoring levels and you see the trough creeping up from one day to the next, it means the kidney is starting to hold on to the drug. It's not clearing it as well as it did yesterday. That's your canary in the coal mine.
A rising trough precedes a rising creatinine.
It's the earliest indicator that you're heading for trouble.
Is it reversible?
Fortunately, in most cases, yes. The proximal tubule cells have a remarkable capacity to regenerate. If you catch it early and you stop the drug, or adjust the dose, the kidney function usually returns to baseline. It might take weeks, but it recovers.
Okay, that's some comfort. But that brings us to the second toxicity. Ototoxicity. The ears. This one is scarier because...
It is usually irreversible. This is the one that keeps infectious disease doctors up at night. With the kidneys, you often have a second chance. With the ears, you don't.
Why the ears? Why are they so vulnerable? And why is it permanent?
It's a combination of factors. The drug accumulates in the perilymph and endolymph of the inner ear. It targets the delicate sensory hair cells, the ones in the organ of Corti for hearing, and the cristae ampullaris for balance. These cells are metabolically very active, so they're packed with mitochondria.
And I read a fascinating theory in Gooden and Gilman about this. It suggests a deep evolutionary link between our mitochondria and bacteria.
Yes, the endosymbiotic theory. Mitochondria are widely believed to be the descendants of ancient bacteria that were engulfed by our proto-eukaryotic cells billions of years ago. And their ribosomes, specifically their ribosomal RNA, is suspiciously similar to bacterial ribosomal RNA.
So the aminoglycoside gets into the perilymph, sees the mitochondria in your ear cells, and thinks, hey, that looks like a 30S ribosome attack.
Essentially, yes. It's a case of mistaken identity on a molecular level. It disrupts mitochondrial protein synthesis in the hair cells, generates a storm of damaging free radicals, and triggers apoptosis-programmed cell death.
And unlike a shark, humans cannot regrow hair cells.
Once they are gone, they are gone. The damage is permanent.
And there are two distinct types of damage here, right? It's not just hearing loss.
Correct. You have auditory or cochlear toxicity, and you have vestibular toxicity. And different drugs in the class have a preference for which one they cause.
So which ones destroy hearing?
Amikacin, kanmycin, and neomycin are the most cochleotoxic. The damage usually starts at the base of the cochlea, which is responsible for processing high-frequency sounds.
So the patient loses the ability to hear high notes first, things like a high-pitched ringtone or birds chirping.
Right. They stop hearing birds chirping. In speech, they lose the sibilant consonants, the S and the sounds. The tragedy is that this is often above the frequency of normal conversation, so they don't notice it until the damage progresses to the lower frequencies.
By the time a patient says, "Doctor, I can't hear you," the damage is severe and permanent.
It's already quite advanced.
And the balance issues, the vestibular toxicity.
Streptomycin and gentamicin are the most vestibulotoxic. This can be even more insidious. It attacks the balance center of the inner ear. The patient might complain of vertigo, dizziness, or ataxia. They feel like the room is spinning when they move their head.
It must be debilitating.
It can be. In severe cases, they can't walk a straight line without falling. It can completely destroy their quality of life and independence.
Is there any way to predict who will get this? What are the risk factors?
The biggest risk factor is duration of therapy. Courses longer than 5 to 7 days are where the risk really climbs. Others include being elderly, having pre-existing renal insufficiency, and combining it with other ototoxic drugs like loop diuretics, furosemide, or even vancomycin.
And there's a genetic component too, isn't there?
Yes, and this is crucial. Some patients have a specific point mutation in their mitochondrial DNA, the 12S rRNA gene, that makes them hypersusceptible. For these individuals, a single standard dose of an aminoglycoside could be enough to cause profound, irreversible deafness.
That is terrifying. Okay, and the third toxicity, the rare one, neuromuscular blockade.
This is rare but acutely dangerous. Aminoglycosides can inhibit the release of the neurotransmitter acetylcholine at the neuromuscular junction. It's a Curare-like effect.
Curare, like the poison used on darts in the Amazon.
The very same. It causes a flaccid paralysis. In a clinical setting, this usually only happens if you give a massive dose very, very quickly, or if you, for example, flush the peritoneal cavity with the drug during surgery and a large amount gets absorbed systemically.
And the result?
Respiratory paralysis. The diaphragm stops working. The patient stops breathing.
Can you reverse it? Is there an antidote?
Yes, you can overcome the block by increasing acetylcholine levels. So an anticholinesterase agent like neostigmine works, as does giving intravenous calcium gluconate. But you have to recognize it fast.
Okay, that's a heavy list of side effects. It really emphasizes why we need that narrow margin mindset. Let's look at the specific weapons in the arsenal. Section 5. Let's start with the workhorse.
That would be gentamicin. This is the drug you will see most often. It's effective, it's incredibly cheap, and we have decades of experience with it. It provides excellent coverage for severe infections caused by gram-negatives like E. coli, Klebsiella, and Serratia. And
it's the go-to for that synergy and endocarditis we talked about earlier.
Yes. For strep, staph, or especially enterococcal endocarditis, gentamicin is usually the partner of choice to add to the beta-lactam or vancomycin.
Then we have tobramycin. I always use the memory anchor T for tobramycin and P for Pseudomonas. Is that a fair way to think about it?
It is a solid anchor. Tobramycin is chemically very similar to gentamicin, but it has slightly better intrinsic activity against Pseudomonas aeruginosa. If you have a severe Pseudomonas infection like a ventilator-associated pneumonia or sepsis from a burn wound, tobramycin is often preferred.
And there's a special formulation for cystic fibrosis patients, right? An inhaled version.
Yes, and it's a brilliant application of pharmacology. CF patients are chronically colonized with Pseudomonas in their lungs. It's what ultimately destroys their lungs over time. We can have them inhale a nebulized solution of tobramycin.
So it goes straight to the site of infection.
Exactly.
Yeah.
This delivers massive concentrations directly to the bronchial treeway, higher than you could ever safely achieve with an IV. But because it doesn't cross membranes well, very little gets absorbed into the blood.
High efficacy, low systemic toxicity.
It's the perfect example. You suppress the bacteria in the lungs without frying the kidneys or ears.
Next up, amikacin. You called this one the heavy hitter.
Amikacin is the tank. It is a semi-synthetic derivative of another aminoglycoside called kanamycin. As we mentioned, its superpower is that bulky side chain that acts like a shield.
It protects the molecule from the graffiti enzymes that cause resistance.
Exactly. It's resistant to inactivation by most of those transferase enzymes.
So when do you use it? Is it a first-line drug?
No, you hold it in reserve. It's a precious resource. If you have a hospital-acquired superbug, a nosocomial infection that is resistant to gentamicin and tobramycin, that's when you pull out amikacin. It's also a key drug for mycobacterial infections, like non-tuberculous mycobacteria and especially MDR-TB, multi-drug-resistant tuberculosis.
Speaking of TB, that brings us to the grandfather of the group, streptomycin.
The original. Isolated from the soil bacterium Streptomyces griseus in the 1940s by Selman Waxman. It was the first effective cure for tuberculosis. It literally earned him the Nobel Prize.
So it changed the world.
It did. Today, resistance to it is widespread, so we mainly use it as a second-line agent for TB. But it still has some very specific niche uses. Plague, caused by Yersinia pestis, and tularemia.
It's fascinating that a drug from the 1940s is still the first-line treatment for the plague.
History stays relevant. But we have to remember, streptomycin is very, very vestibulotoxic. It really messes with a patient's balance. It can also cause deafness in newborns if used during pregnancy.
Now let's fast forward to the modern era. Plasmycin. This was approved fairly recently, in 2018. Why did we need a new aminoglycoside?
Because of the rise of CRE, carbapenem-resistant enterobacteriaceae. These are the nightmare bacteria of modern medicine. They're resistant to almost everything we have, including carbapenems, which used to be our last resort.
The ultimate superbugs?
Right. Plasmamycin was specifically engineered to withstand almost all of the known aminoglycoside modifying enzymes. It's approved for complicated urinary tract infections, or CUTI, but we are looking at it for these super-resistant systemic infections as a last-ditch option.
And an interesting note from the text, plasmamycin has only been studied with once daily dosing. It seems the new generation is built for the new dosing strategy.
Correct. The old TID, or 3 times a day, dosing, is becoming a historical relic for this class.
We have a couple others mentioned, neomycin and kanamycin.
These are the 2 toxic for IV group. Neomycin is notoriously nephrotoxic and ototoxic.
Yeah.
You never, ever inject it systemically. But you will see it in topical creams, like Neosporin, or used orally to sterilize the gut before bowel surgery.
Or for hepatic encephalopathy.
Yes, to kill the ammonia-producing bacteria in the gut. Since it isn't absorbed, it acts locally.
And spectinomycin, it's kind of an outlier.
It's the cousin. Technically, it's an aminocyclitol, not a true aminoglycoside. It lacks the amino sugars and the glycosidic bonds. Its only real job these days is treating gonorrhea in patients who are allergic to penicillin or have strains resistant to other drugs. It's a very niche player.
Okay, we have the map of the drugs. We understand the risks. Now let's put on the white coat and step into the hospital. Section 6, clinical integration. Katsung gives us a great case study that puts all of this into practice.
Let's set the scene. You have a 45-year-old male patient. He's been admitted to the burn unit with 40% total body surface area burns. It's day 3 of his hospital stay. He suddenly spikes a high fever, his blood pressure drops, he's hypotensive, and his white blood cell count spikes.
This is a classic setup for sepsis. And in a burn ward, who is the usual suspect?
The boogeyman of the burn unit is Pseudomonas aeruginosa. It thrives on that necrotic burned skin. It is aggressive, and it can be incredibly lethal.
So you need to act fast. You can't wait 24 to 48 hours for cultures to come back. You need empiric therapy right now.
Right. And you are not going to play games with monotherapy here. For suspected Pseudomonas sepsis, you need double coverage to ensure you hit the bug and to help prevent resistance from emerging during treatment.
So you'll start an anti-pseudomonal beta-lactam, something like cefepime or piperacillin tazobactam.
That's your backbone. But you need a second agent, something with a different mechanism of action.
Enter the aminoglycoside. And we choose tobramycin.
We choose tobramycin.
Why tobramycin specifically?
Remember our anchor? T for tobramycin, P for Pseudomonas. It just has slightly better coverage against this specific bug than gentamicin does.
Okay, now here is where the rubber meets the road. Dosing. The patient weighs 70 kilograms. We check his labs. His serum creatinine is 0.8 milli-GDL. We run the numbers, maybe using the Cockcroft-Gault equation, and we calculate his creatinine clearance. It's roughly 90 ml/min.
So that is normal kidney function.
So we have a green light for once daily dosing.
We do. His kidneys are working well enough to handle the washout. So we look at the guidelines. For once daily dosing in a serious infection, we target 5 to 7 milligrams per kilogram.
And he's septic, so we should be aggressive.
Let's be aggressive. We'll go with 7 milligrams per kilogram.
So 70 kilograms times 7 lg kilogram is 490 milligrams. Let's round it to 500 for a standard dose.
So we write the order. Tobramycin 500 milligram IV every 24 hours. We hang that bag and we run it in over 60 minutes to avoid that neuromuscular blockade issue.
We create that massive peak concentration, the sledgehammer. We obliterate the bacterial population, but now how do we monitor him? We don't want to cause permanent harm.
This is critical. With once daily dosing, we don't need to check a peak level immediately after the dose because we know it's going to be high. That's the entire point. What we need to check is that the washout is actually happening. We need to prove his kidneys are clearing the drug effectively.
So when do we draw the blood for that?
We usually draw a single random level somewhere between 6 and 14 hours after the dose started. Let's say we draw it at hour 10. We take that number and we plot it on a special graph called a nomogram. The Hartford nomogram is the most famous one.
It's like a growth chart for drug levels.
Exactly. The nomogram has zones on it. If the level falls in the safe zone, it tells us that his clearance is adequate. It predicts that by hour 24, when the next dose is due, the level will be undetectable. We can safely give the next dose on time.
And if it lands in the danger zone on the chart?
If it's too high, it means he isn't clearing it fast enough. But here's the key. We don't lower the dose. We extend the interval. Instead of giving the next dose at 24 hours, the nomogram might tell us to wait and give it at 36 or 48 hours. We preserve the sledgehammer peak, but we give his kidneys more time to wash the drug out.
That is a crucial distinction. We adjust the time, not the dose, to maintain efficacy while ensuring safety.
Correct. Now contrast this with the old school method. If we had done the every 8-hour dosing, we would have to be obsessive. We check a peak level 30 minutes after the infusion finished to make sure we are high enough to kill targeting 5 to 10 mcgml. And a trough level right before the next dose is due to make sure we aren't accumulating targeting less than 2 mcgml.
It's much more labor-intensive and probably more prone to error.
Far more. Once daily dosing with nomogram monitoring is simpler and safer for patients with good renal function.
And finally, the most important decision with these drugs, stopping.
The stop signal. You are always thinking about your exit strategy. The risk of toxicity shoots up after 5 to 7 days. You want to de-escalate as soon as you have more information.
So let's say 48 hours later, the blood cultures come back from the lab. It is Pseudomonas aeruginosa. And luckily, the sensitivity report shows it is susceptible to the cefepime we started.
Great news.
So what do?
You stop the tobramycin immediately. You continue with just the cefepime. You use the aminoglycoside as a bridge to stabilize the patient during the initial crisis. And now that you have a safer, targeted bullet, you switch.
Get in, kill the bug, get out.
That is the motto for aminoglycoside therapy. Don't linger.
It's a powerful conceptual map. We've covered a lot of ground today. From the polarity of the molecule all the way to the physics of the inner ear, let's bring it all home. What are the absolute key takeaways our listeners need to walk away with?
Okay, let's boil it down. I think there are 5 core concepts to lock in. First, mechanism. Aminoglycosides are bactericidal. They bind irreversibly to the 30S ribosome, causing a blockade of initiation and, crucially, the misreading of mRNA, which creates toxic proteins and leaky membranes.
Got it. Number 2.
Second, the oxygen key. They require oxygen-dependent active transport to enter the bacteria. Remember that. They do not work on anaerobes or in abscesses.
Third,
dosing logic. They are concentration-dependent killers with a significant post-antibiotic effect. This is the entire rationale behind high-dose once-daily administration to maximize the sledgehammer kill while allowing a washout period to protect the organs.
Fourth, synergy.
Fourth, synergy. They struggle with the thick cell walls of gram-positives, so they work best when a beta-lactam or vancomycin opens the door. This is absolutely critical for treating something like endocarditis.
And finally, the big one.
And finally, toxicity. Respect the narrow margin. Watch for nephrotoxicity, which is often reversible if you catch it, and ototoxicity, which is often permanent and devastating. Monitor your trough levels and your renal function religiously.
You know, it really strikes me that in this era of increasing antibiotic resistance with CRE and other superbugs, we are circling back to these older, more toxic drugs.
We are. We have to. It forces a very difficult philosophical question in medicine. We invest so much in safety, in that do no harm principle. But when a patient is dying of sepsis from a pan-resistant superbug, the harm of potential deafness becomes secondary to the harm of certain death.
The terrible trade-off.
It is.
Yeah.
The narrow margin is where the art of medicine lives. How much risk of organ damage is acceptable to save a life? There's no easy answer to that.
That is a profound thought to end on. It's not just about the chemistry. It is absolutely about the judgment.
Always.
Listeners, thank you for diving deep with us. As always, this conversation is a map. It is not the territory. You need to go back to the source. Read Katsum Chapter 45 for the clinical tables and the dosing nomograms. Look at the molecular diagrams of ribosomal binding in Goodman and Gilman, Chapter 58. That is where the real mastery happens.
Reading is essential.
Until next time, stay curious.